Okay, before we left off last time we were talking, we were about to get into a little bit more detail about hormone interactions. Now, most cells are sensitive to more than one hormone at a time, and this can cause there to be interactive effects if more than one hormone is signaling the same target tissue. Synergistic effects are where multiple hormones act together for a greater effect than either of them added together separately would cause. So basically, the sum of the effects is greater than simply adding up the effects of the individual parts. For instance, we can see synergism between follicle stimulating hormone and testosterone on sperm production. When they're both being produced together, you make more sperm than the effect you would expect from either one of them acting individually on their target tissue. In this case, the target tissue would be the spermatogonia. There's also permissive effects, and this is where one hormone sets the table for another hormone. Estrogen, for instance, prepares the uterus for the action of progesterone. So, in order for progesterone to exert its effect, estrogen has to set the table, generally by causing the expression of the appropriate receptor. And then, once progesterone arrives, the effect on the target cell is easily seen. And then you can also have antagonistic effects, and this is where one hormone opposes the action of another hormone. As an example, we know that insulin lowers blood glucose and glucagon raises it. So these are hormones that act um, as antagonists. They have opposing effects on the same target cell. Now, one of the things that happens once the hormone is given off is that we have to get rid of it. We don't want it persisting in the bloodstream. Otherwise, it's going to continue to signal the target tissue, and this can end up producing, in the long run, deleterious effects. So they've got to be turned off after they've served their purpose, and most hormones are taken up and degraded by the liver and the kidney, where they're excreted in the bile or the urine. The metabolic clearance rate is simply defined as the rate of hormone removal from the blood. And the half-life of a hormone is the time required to clear 50% of that hormone from the human body. And so different hormones are going to have different half-lives. The faster the MCF, the shorter the half-life is going to be. Um, Essentially, uh, the higher this clearance rate, the less time active hormone is going to persist in the bloodstream, and as a result, the shorter the amount of time it's going to be able to exert its effect. Now, the next topic we want to segue into is stress and adaptation, and we're going to give a physiological definition of stress and discuss how the body adapts to stress through its endocrine and sympathetic nervous systems. So what we want to look at first here is the action of epinephrine on a liver cell, because one of the first stress hormones to be produced is epinephrine. Remember that it's generated by the adrenal medulla. Can be caused by any stimulus that upsets homeostasis and threatens one's physical or emotional well-being. And what this leads to is something called the general adaptation syndrome that has three distinct stages. This is consistent in the way that the body reacts to stress. Typically, we see elevated levels of epinephrine and glucocorticoids. Initially, this is adaptive, and the idea behind the elevated epinephrine and glucocorticoids is to increase the blood pressure, increase the amount of glucose in the blood, increase the amount of oxygen in the blood by stimulating both the heart rate and the respiratory rate. And this allows you to deal with the acute stage of the stress response more easily. What eventually happens, as we're going to see after this quick video on the action of epinephrine on hepatocytes, is that eventually this gives way to the stage of resistance and exhaustion, and these are maladaptive states. Essentially, after the stress has persisted for a period of time, the body begins to exhibit deleterious effects as a result of these elevated levels of glucocorticoids and epinephrine. So let's take a look at how epinephrine actually exerts its effects, and then we're going to talk a little bit about the general adaptation syndrome.
Epinephrine is one of many hormones that is water-soluble, hydrophilic, and therefore unable to cross the hydrophobic plasma membranes of its target cells. Instead, it binds to receptor proteins located in the plasma membrane and does not enter the cell. When epinephrine binds to beta-adrenergic receptors on the liver cell, G proteins on the inner side of the cell membrane are activated. Each G protein is composed of 3 subunits, and the binding of epinephrine to its receptor protein causes one of the G protein subunits to dissociate from the other 2. The G protein subunit which dissociates from the others carries a GDP, which is replaced by GTP when the subunit is activated. The activated G protein subunit then diffuses within the plasma membrane until it encounters adenylyl cyclase, a membrane enzyme that is inactive until it interacts with the G protein subunit. When activated by the G protein subunit, adenylyl cyclase catalyzes the formation of CAMP from ATP. The CAMP formed at the inner surface of the membrane diffuses within the cytoplasm, where it binds to and activates protein kinase A, an enzyme that adds phosphate groups to specific cellular proteins. In liver cells, protein kinase A phosphorylates and thereby activates another enzyme called phosphorylase, which converts glycogen into glucose 6-phosphate. The glucose 6-phosphate is then converted to glucose. Through this multi-step mechanism, epinephrine causes the liver to secrete glucose into the blood during the fight or flight reaction.
Okay, guys, we want to finish up the chapter on the endocrine system. We had left off last time we spoke talking about the alarm reaction. The idea behind this is that the human body has a series of phases that it goes through when it responds to a prolonged stress that are initially adaptive but eventually end up taking a toll on homeostasis. So when we look at the initial phase of the alarm reaction, what we see is a flood of norepinephrine from the sympathetic nervous system and from the adrenal medulla. Remember that the adrenal medulla is essentially a modified neuron that secretes massive amounts of epinephrine into the bloodstream. This prepares the body for the flight or fight response. Stored glycogen is consumed because of the need for energy, and it increases aldosterone and angiotensin levels. So what happens there is that angiotensin, which essentially causes you to retain fluid and also engages in vasoconstriction, causes your blood pressure to rise. And the idea behind this is that we deliver more blood per unit time to tissues that need it. Aldosterone is your salt retaining hormone, and remember that that's created by the adrenal cortex, specifically the outer layer of the adrenal cortex. So as you retain sodium, you also tend to retain fluid. In the kidneys, remember that water will follow solutes wherever they happen to go. So the initial response here is to increase your blood volume and as a result increase your blood pressure, increase the sugar content of the blood, which is also going to increase your blood volume and your blood pressure because of the osmotic effects of glucose, and prepare you for this, what the body perceives as an emergency situation. But as this stress level persists, what we enter now is the stage of resistance. After a few hours, glycogen reserves disappear, but the brain still requires glucose. Remember that glucose is the only type of fuel that the central nervous system can use to any significant extent. And that's why the body will take any route that it can to reserve all glucose nutrients for the nervous system while other tissues can persist on other fuel. This provides alternate fuels for metabolism for other tissues. In this stage, what you see is massive amounts of secretion of cortisol, and this tends to increase blood glucose levels as well. Remember that cortisol is secreted by the middle layer of the adrenal cortex in response to falling blood glucose levels. The hypothalamus, in response, produces corticotropin releasing hormone. This is a um, hormone that's going to command the anterior pituitary to release ACTH. Remember that ACTH is adrenocorticotropic hormone. And what tissue does that target? The adrenal cortex. Okay. As a result, the adrenal cortex secretes large amounts of glucocorticoids, cortisol being the major one, and this promotes the breakdown of fat for gluconeogenesis. Remember that gluconeogenesis is the generation of carbohydrates from non-carbohydrate precursors. And this is all in an effort to supply the nervous system with the necessary fuel to keep you going during the resistance stage of this stressful situation. The problem is that in the long term, this is actually going to be detrimental to our overall health. Cortisol has a glucose sparing effect in that it inhibits protein synthesis and leaves free amino acids open for gluconeogenesis. Remember that gluconeogenesis is carried out by the liver, and there are adverse effects that result from this excessive amount of cortisol in your system. It suppresses immune function. Remember that corticosteroids are immune suppressants. They dampen the inflammatory response. This increases susceptibility to infection and can cause ulcers. It causes lymphoid tissues to atrophy, meaning die as a result of disuse, antibody levels to fall, and as a result, wounds also heal very poorly. And so now we're starting to have negative effects on our overall homeostasis. The next thing that we see is the stage of exhaustion. When the stress continues for several months, the fat reserves disappear and homeostasis is overwhelmed. And this is an extremely deleterious state. It's marked by rapid decline and death. We see protein breakdown and muscle wasting as the body attempts to scavenge any tissue it can for fuel. And we see a loss of glucose homeostasis because the adrenal cortex stops producing glucocorticoids. Aldosterone promotes water retention and hypertension. This causes us to conserve sodium, and it also speeds the elimination of potassium and protons in the urinary system, and this screws up our body's pH, leading to hypokalemia and alkalosis, and this can hasten death. Remember that it's very important for the human body to keep the pH within certain tight limits, or else chemical reactions will start to shut down. Death results from heart and kidney infection or from overwhelming infection, again, primarily due to this immune suppression. There's other types of signaling molecules in the body that we want to touch on before we leave this chapter. These are eicosanoids and paracrines. So we're going to explain what eicosanoids are and how they're made. We'll ID some classes and functions of eicosanoids, and we'll describe several physiological roles for prostaglandins. Paracrines are sort of like hormones, except that they don't travel nearly as far in order to produce their effects. These are chemical messengers that diffuse a short distance and they stimulate nearby neighboring cells. They're unlike neurotransmitters in that they're not produced by neurons, and they're unlike hormones in that they're not transported by the bloodstream. A single chemical can act as both a hormone, a paracrine, or a neurotransmitter in different locations. The point being that the signaling mechanism is going to be different in all three. Here's an example. Let's take histamine. Okay, this is produced by mast cells in connective tissue, and it causes smooth muscle vasodilation. Nitric oxide comes from the endothelia of blood vessels and causes vasodilation. This is another paracrine signaler. And somatostatin is generated by gamma cells of the pancreas, and it inhibits the secretion of the alpha and the beta cells. Remember that the beta cells of the islets of Langerhans produce the insulin, which raises blood sugar. Which lowers blood sugar, and the alpha cells produce glucagon, which raises blood sugar. Catecholamines diffuse from the adrenal medulla into the cortex and can have an effect on their function as well. Eicosanoids are an important family of paracrines. So what are some relevant eicosanoids? These are all fatty acid derivatives. Okay, the main fatty acid that's used to produce these eicosanoids is called arachidonic acid. It is a long chain fatty acid with a few double bonds in it. Okay, lipoxygenase converts arachidonic acid into leukotrienes, and remember, I like to look at a name here. Okay, leukotrienes. Leuco means white. Triene means 3 double bonds in the molecule. Okay, and what does this control? It controls allergic and inflammatory reactions. So what is its target tissue? White blood cells. Hence the prefix leuco when we talk about leukotrienes. Cyclooxygenase converts arachidonic acid into 3 other types of eicosanoids. Prostacyclins inhibit blood clotting and vasoconstriction. Thromboxanes are made by blood platelets after injury. They override prostacyclin and stimulate vasoconstriction, and this promotes clotting due to the fact that it slows blood flow. Prostaglandins are another class. Prostaglandin E relaxes smooth muscle in the bladder, the intestines, the bronchioles, the uterus, and it also stimulates contraction of blood vessels, so it promotes vasoconstriction, while prostaglandin F opposes the effects. So this is the flip side of this type of signaling. Last thing we want to talk about in this chapter are endocrine disorders, and what we'll do is explain some general causes and examples of hormone hypo and hypersecretion. We'll briefly describe some common disorders of pituitary, thyroid, parathyroid, and adrenal function, and we'll describe the causes and pathology of diabetes mellitus. Variations in hormone concentration and target cell sensitivity have major effects on the body. When we have hyposecretion, what results is inadequate hormone release. We're not making enough of the chemical signal to get the job done. This can be caused by a tumor or a lesion that destroys the gland or interferes with its ability to receive signals from another gland. So it may have an inability to be regulated by the gland that controls it, or it may, in fact, simply be incapable of producing the desired hormone. What are some examples of this? Well, head trauma can affect the pituitary gland's ability to secrete ADH, also known as vasopressin. Diabetes insipidus can result in chronic polyuria. Okay, well, what is polyuria? Well, poly means many, urea means to urinate. Okay, so what happens as a result of this loss of ADH is that we have no ability to retain our water anymore. We can't control that as effectively as we did before. This results in polyuria, which can lead to dehydration. Why does this happen? Well, trauma can result from accident or severe injury, right? There's also another way that we can interfere with the gland's ability to operate. Autoantibodies, which are basically the agents of autoimmunity, can fail to distinguish a person's own gland from foreign matter and can move in and destroy it. So your immune system can actually act as an agent of disease in this case and bring about the negative effects that we associate with hypo or in some cases hypersecretion. Hypersecretion is the overproduction of a particular hormone. Basically, the gland no longer is responding to the homeostatic signals of the body and is producing hormone on its own agenda. Okay, this can be caused by tumors. It can also be caused by autoimmune disorders. There are antibodies that can mimic the effects of tropic hormones It can bind receptors on the endocrine gland and leave the switch stuck in the on position, and as a result, you make massive amounts of this chemical signal. Examples of this include pheochromocytomia, which is a tumor of the adrenal medulla causing it to secrete excessive amounts of epinephrine and norepinephrine, and also toxic goiter, also known as Graves' disease, which results from an autoantibody that mimics the effect of thyroid stimulating hormone on the thyroid and causes it to hypersecrete. So, autoimmune disorders, when we're talking about the endocrine system, can either cause an overproduction of the desired signal or an underproduction of the desired signal. It can act in either direction depending on the nature of the autoantibody. Let's look at some pituitary disorders. This is an example of pituitary hypersecretion. We're looking here particularly at the loss of regulation of human growth hormone, HGH. When we have an overproduction of this prior to the end of puberty, what results is gigantism. If it happens after the epiphyseal plates seal, we have a condition known as acromegaly, which is characterized by a thickening of bones and soft tissue in adults. We see this especially in the hands, the feet, and the face. They become greatly enlarged. Problems in childhood and adolescence result in gigantism if we have hypersecretion of human growth hormone. And as you can probably guess, if we have a lack of secretion of human growth hormone um, up to and towards the end of puberty, it can result in dwarfism, where we don't achieve our normal adult height. So, what do we do about these kinds of disorders? Well, in the case of a lack of human growth hormone, we can supply growth hormone as an injectable and achieve normal adult height. And at that point, we've solved most of the problems associated with prepubescent hyposecretion of HGH. But what do we do about this oversecretion of growth hormone? Well, one thing that we can do is we can resect the portion of the pituitary that's producing the hormone. And this is what I was talking about earlier in the chapter. Remember that the pituitary gland sits inside the pituitary fossa, which is a component of the sphenoid bone. And so to access that, what you have to do is go through the nasal cavity, crack through the sphenoid, and remove that portion of the pituitary that's producing the hormone. But what do we do about the hormone that's already in your system, that has already been produced by the gland? And the answer there is that we have growth hormone antagonists that can blunt the effect of human growth hormone and stem the tide of this massive overgrowth. Probably the person that you most easily associate with this disorder is a gentleman named Andre the Giant. For those of you who've ever seen the movie The Princess Bride, Andre the Giant was both a giant and he was also an acromegalic. And the reason for this is that he had oversecretion of human growth hormone um, through puberty and after puberty, and it resulted in his massive increase in size. And we're going to look at a video in class that's going to show you some of the consequences of this oversecretion. The fact that when you mess with one of the body's organ systems, in this case the endocrine system, there are profound effects in other body systems that cause disease and in some case death. Okay, congenital hypothyroidism is essentially an underproduction of thyroid hormone. Now, this could be as a result of the gland failing to respond to thyroid stimulating hormone, or it could be as a result of the gland being incapable of making thyroid hormone for any of a number of reasons. Hyposecretion can be present at birth. Generally, if we have a lack of thyroid hormone during human development and through infancy, it has a profound effect on the central nervous system and can result in a condition known as cretinism, where we see cognitive deficit, basically low IQ, and also short, squat stature. We treat this with oral thyroid hormone. If this happens after infancy and childhood, what we see is a condition called myxedema coma. This is adult hypothyroidism, and we treat this with oral thyroid. Um, These conditions are often characterized by goiter. Okay, it's one of the odd aspects of thyroid dysfunction that both an inactive and an overactive goiter tend to enlarge for different reasons. And I'm sorry, an inactive or overactive thyroid gland tend to enlarge into a goiter for slightly different reasons. And we can see an example of this here. Okay, this is a thyroid gland that has increased in size. This is an example in this photograph of endemic goiter. This results from dietary iodine deficiency. As a result, there's no thyroid hormone produced. As a result, there's no feedback to the pituitary gland. And as a result of that, thyroid stimulating hormone is constantly being produced, and this causes the gland to hypertrophy. Okay? In toxic goiter, we have autoantibodies that mimic the effect of thyroid stimulating hormone and cause hypersecretion. This causes the thyroid to overgrow, and it also results in a massive production of thyroid hormone, um, even though the body doesn't need the hormone in that massive an amount. Now, hyperactive thyroid generally results in an increased basal metabolic rate, low amount of body fat, and an intolerance of high temperatures. Whereas in hypoactive thyroid, what we tend to see is weight gain. We tend to see an intolerance to cold temperatures, and we see a very low basal metabolic rate. Hypoparathyroidism is a much more dangerous condition. Remember that parathyroid hormone has the effect of raising blood calcium by demineralizing bone. And it's very important that we keep the optimal amount of calcium in the blood, because calcium is not just used to make bone hard, it's also used in muscle contraction and in nerve transmission. We treat this by surgical excision of the affected parathyroid gland. Basically, we cut out the tissue that's over secreting the thyroid. In hypoparathyroidism, what we have here um, is a lack of production of parathyroid hormone. Well, what would that result in? Well, if parathyroid hormone elevates blood calcium, a loss of parathyroid hormone is going to reduce blood calcium. Okay, this can result from an autoimmune attack on the parathyroid, causing it to die. It can also result from an accidental surgical excision of the gland during thyroid surgery, but the effects are quite severe. You see fatal tetany, basically muscle contraction that proceeds unabated, and in 3 to 4 days, we have a rapid decline in blood calcium level, and eventually followed by death. Okay, um, why death? Well, think about the muscles that have to contract properly to keep you alive, your heart and your diaphragm, just to name a couple, right? And if those can't work properly, then it's going to be very difficult for you to live. Hyperparathyroidism is a result of excess parathyroid hormone secretion. This can result from a tumor, okay? Basically, the parathyroid gland's not listening to the fluctuating calcium levels in the blood or in the interstitial fluid, and starts to make all kinds of PTH pell-mell. And you have to surgically excise the defective tissue in this case. There's not going to be an effective medical treatment using drugs only, generally, that can overcome this particular type of problem. You can't use stuff like Fosamax and exogenous um, calcium, because the excess parathyroid hormone overwhelms those effects and um, essentially masks any of those types of treatment. You have to get rid of the tissue that's causing the problem in the first place. Bones become soft, fragile, and deformed. Why is this? Well, they're losing calcium. As they lose calcium phosphate. As they lose calcium phosphate, the calcium phosphate levels in the blood go up. The mineral component of the bone starts to dissipate, and what you see is early onset osteoporosis. It can also promote renal calculi, and for those that don't know, renal calculi is another name for kidney stones. Kidney stones are a horrible condition, resulting in a solid mass getting lodged in the ureter. This results in a buildup of pressure in the ureter as the urine backs up into the kidney, and the pain is, for guys, it's a combination of feeling constipated and feeling like you've been kicked in the crotch, and I can tell you this from firsthand experience. For women, you see abdominal distension, extreme pain in the abdominal pelvic region. This is an example of something called referred pain, where the pain seems to be emanating from one place, but it's actually coming from the urinary system. And the reason for that, essentially, is because the pain signals, in this case, that are coming from the ureter and the kidney, come into the spinal cord at the same place that the pain signals that come from the lower GI enter the spinal cord. And so the brain has a difficult time distinguishing between those two kinds of pain, and it seems to be coming from a place that it's not. Generally, what's diagnostic for renal calculi is a condition called hematuria. This is blood in the urine. Okay, remember, break the name down. Hemo meaning blood, urea meaning urine. And the reason for this generally is because the stone, as it descends through the ureter, is very sharp, and it'll cut the ureter and cause it to bleed. And the treatments generally are drinking a lot of fluid in an attempt to either dissolve or to force the stone through the ureter so that the pain goes away. Or if the stone's too large, you can use ultrasound or surgical resection in some cases. Okay, adrenogenital disorder is basically adrenal androgen hypersecretion. This often accompanies Cushing's syndrome. We see enlargement of the sexual organs in children and early onset puberty called precocious puberty. Newborn girls can exhibit masculinized genitalia due to the fact that these androgens are similar in chemical structure to testosterone, and as a result have similar effects on the target tissue. Masculinizing effects that we see on women include increased body hair production, deeper voice, and in some cases beard growth. And so how do we treat? We use androgen antagonists. Now, Cushing's syndrome is a little bit different. Cushing's syndrome is excess cortisol secretion, so this is a disorder of the adrenal cortex. We see hyperglycemia followed by hypertension, weakness, and edema. Okay, now why would that be? Well, remember what cortisol does. Elevates blood glucose. If you elevate blood glucose, obviously you're going to have hyperglycemia. But what's going to follow? Remember that as sugar enters the bloodstream, it's osmotically active, and as a result, it's going to draw water to it. This is going to increase blood volume and blood pressure. You're also going to see weakness and edema. The edema is simply the result of swelling, okay, as a result of this disorder of glucose partitioning. And the weakness is a combination of essentially the loss of ready fuel and the combined effects of where the fluid is going. You see rapid muscle and bone loss due to protein breakdown and abnormal fat deposition in the body. This individual has Cushing's, so you can see what we have here is what's called a moon face. We also see something called buffalo hump, and again, this is a result of abnormal amounts of fat being deposited. Okay, so what's happening here is that we're converting some of this excess fuel into fat for future storage. Okay, diabetes mellitus is the most prevalent metabolic disease in the world. It comes in several flavors. It's basically a disruption of metabolism due to hyposecretion or inaction of insulin. The symptoms include polyuria, which is excess urine output, polydipsia, which is intense thirst, which follows from the polyuria because you dehydrate, and polyphagia, which is due to the fact that you're losing fuel, right? You're peeing sugar. It's relieved it's revealed by elevated blood glucose and glycosuria. This is glucose in the urine, as well as ketonuria, which is ketones in the urine. Now, why do the ketones show up? The ketones show up because when we interrupt or interfere with the insulin signal, the cells basically don't have a way to get the glucose out of the blood to use it for fuel. And so what they have to do is go to the next most available fuel source, and that's fat. Well, when the cell attempts to burn the fat in an effort to try and trap that energy in the form of ATP to do cellular work, what happens is that the fat doesn't get completely combusted. And the byproducts are what are called phenylketones, things like alpha ketobutyrate and acetoacetate. And these are volatile compounds. They enter the bloodstream and they're evacuated by the respiratory system. People that are in the throes of what's called ketoacidosis, which is one of the hallmarks of diabetes mellitus, have breath that smells like nail polish remover. And they tend to lose massive amounts of weight, massive amounts of water, okay, because of the fact that they are burning their fat in an incomplete fashion. The reason that we're losing glucose in the urine is basically we're overloading the kidney's ability to recover glucose from the filtrate that is produced in the kidneys. It's eventually going to be urine and put that back into the blood. So as a result of that, the glucose stays in the filtrate and as a result stays in the urine. And what that does, again, is draws water into the filtrate, increasing the filtrate volume, and by extension, increasing the volume of urine. So you dehydrate very easily. Excess glucose enters the urine, the water follows it, and we see polyuria, dehydration, and thirst. So what are some of the different ways that diabetes mellitus can manifest itself? Well, in type 1 or juvenile onset diabetes mellitus, what happens is we have a lack of production of insulin. This is generally due to an autoimmune attack on the beta islet cells of the pancreas that wipes them out. So they're not there anymore, they're just gone. And so the way that we manage the symptoms is through daily insulin injections to control blood glucose or through an insulin inhaler. The patient needs to monitor their blood glucose levels and have a controlled diet. There is thought to be a hereditary susceptibility to this condition if these individuals are infected with certain viruses, such as rubella and cytomegalovirus. Autoantibodies that are generated following these attacks will destroy the pancreatic beta cells and wipe out the body's ability to make insulin. Now, you might think, well, how does that work exactly? And the best way that I can illustrate this is just kind of follow me here while I do some drawings. Let's say that in the course of your activities of daily living, you encounter a pathogen. Okay, let's say this little guy here is a pathogen. And on the surface of this pathogen is an antigen. Okay, an antigen is like an ID tag. Okay, it's a collection of molecules. The molecules could be proteins, it could be fats, they could be carbohydrates, it could be combinations of all three. There's any number of ways to make an antigen. But let's say that you're exposed to this little pathogen right here. Well, what will happen is due to the fact that these molecules don't resemble your own antigens, your immune response will be to generate an antibody that will specifically bind to this set of antigens and wipe it out. So where I'm drawing here our fictional antibody, okay, that's going to destroy this pathogen. This pathogen could be a bacteria, could be a fungus, could be a pollen grain, could be something non-living, right? And so we wipe this guy out, okay? So he gets destroyed, he gets taken out, okay? But we have a problem. And the problem is that we still have a lot of this antibody around. So the thing about that is that if we have a lot of this antibody floating around, okay, so let's imagine thousands of these in the bloodstream and in the tissues, okay, and he kind of has nothing to do, all right, kind of has nothing to do. If it so happens that one of our own body cells. Okay, so let's draw human body cell here, and there's the nucleus. Okay, and there's the DNA in there. Okay. And let's say that on our human body cells, we have an antigen that is similar, okay, but not identical. Okay, instead of two jagged bumps like it is over here, we have like a smooth bump and a jagged bump. It's just this molecular shape on the surface. Well, what can happen is that because you've got so much of this antibody, you can have a very weak interaction between these antibodies and these antigens that are on your own body's tissues. And even if that antibody only binds, say, 10% of the time, because you now have so much of it, what happens is that's the same as effectively binding this antigen all the time. And so what will happen as a result is that you'll start to mount an autoimmune attack on your body's own tissues, and you'll start to wipe this tissue out. Well, this is bad news, okay, because this tissue may be important. You might need this in order to survive. And this is thought to be one of the major mechanisms whereby autoimmune diseases do their dirty work. Now, it's not the only possible mechanism. You could also have mutation in the lymphatic system or mutation in your own tissues. That happens occasionally. You can have a breach of a barrier between the immune system and a protected tissue. Okay, there are several tissues in the body that have what we call immune privilege. Examples are the corneas of your eyes, your liver, and the duct cells, okay, in your reproductive system. In the male, we're talking about the seminiferous tubules and the vas deferens, and in the female, we're talking about the ovaries and the fallopian tubes. Okay, those happen to be um, walled off from the immune system. Not to mention the central nervous system, your brain and your spinal cord, also have this magical property of immune privilege, and so you don't have to worry about the phenomenon of rejection normally when you're dealing with those tissues. But every other tissue, since it's in intimate contact with the immune system, is subject to this effect, to this immune surveillance and the potential negative effects that result from autoimmunity. Okay, so this is thought to be one of the mechanisms. So this is why often we see these kinds of things following infections, okay, because it's thought that these agents bring in weirdo antigens that your immune system recognizes, and then these antibodies hang around and they cause all kinds of problems. Okay, type 2 diabetes mellitus is different. This is the kind of diabetes that you can get through a sedentary lifestyle. The problem here is insulin resistance. This is a failure of the target cells to respond to the insulin. The risk factors include age. We see this in older individuals. Also obesity and ethnicity. It's more common in Native Americans, Hispanics, and in Asians. And we treat this with a weight loss program and exercise, since loss of muscle mass causes difficulty with the regulation of glycemia. And there's several reasons for that. Okay, we'll get into them in a minute. One of these is that adipose signals interfere with glucose uptake into most cells. But the other reason, a very simple reason, is because in order to gain massive amounts of weight, what you have to do is take in more calories than you burn. All right, and if you take in more calories than you burn, what happens is that you're constantly flooding the bloodstream with massive amounts of, in this case, carbohydrates. Well, what happens as a result is that the insulin produced by the pancreas is early and often. And essentially, if you overload the target tissue with the insulin signal day after day after day, eventually the target tissue will quit listening to the insulin signal and you'll be resistant to your own insulin. Okay, you'll just, target tissue will say, I don't care if there's insulin around, I'm not going to respond to the signal. And so what happens? Well, blood glucose begins to climb, and you see all the other symptoms that we associate with type 1 diabetes, with the exception that these individuals have insulin in their system. It's just that the insulin is ineffective. We can use oral meds that can improve insulin secretion, or we can use target cell sensitivity meds, basically that increase the ability of the insulin to have some effect on their target. Okay, um, so what I've got for you next here is just a little video that talks about blood sugar regulation in diabetics. Okay, so take a listen to this.
As blood glucose levels increase after a meal, non-diabetics release insulin. Insulin signals the cells in muscle and liver to take up glucose from the blood. This causes blood sugar levels to return to normal. In untreated type 1 diabetes, no insulin is released and blood sugar levels remain high. Type 1 diabetes is treated by injection of exogenous insulin. This insulin has the same effect as normal insulin. In type 2 diabetes, insulin is released in response to a blood glucose increase, but the cells do not receive the signal. One treatment for type 2 diabetics is Avandia, an oral thiazolidinedione that increases cell sensitivity to normal insulin. An effective treatment for obese patients is metformin, an oral medication that blocks liver synthesis of glucose.
Okay. In pathogenesis, cells cannot absorb glucose and have to rely on fat and protein for energy needs, and as a result, we see weight loss and weakness. Fat breakdown increases the amount of free fatty acids and ketones in the blood, and then we see ketonuria and ketoacidosis as a result of these incompletely burned components, these byproducts of fatty acid breakdown. Ketonuria promotes osmotic diuresis, so you lose a lot of water through the urinary stream. And we also see a lot of loss of sodium and potassium, as well as irregular heartbeat and problems with nerve transmission. Ketoacidosis occurs as the ketones build up and decrease the pH of the interstitial fluid and of the blood. We see deep gasping breathing and diabetic coma as the terminal result. So again, the outcome is not good if this is allowed to go to its endpoint. Chronic pathology leads to neuropathy, basically nerve cell death, and cardiovascular damage from arteriosclerosis and microvascular disease. Arterial damage in the retina and the kidneys is common in type 1, and arteriosclerosis leading to heart failure is more common in type 2. Now, why are we having these issues with arterial damage? Well, let's look at the problem in type 1. The retina and the kidneys have big problems. Well, why are they having big problems? They're having big problems because the blood pressure is very high, for one thing, and the blood is very glucose rich for another. Okay? Well, the capillaries, which are found in the distal parts of the body, they're also found in the retina, and they're also found in the kidneys. They're delicate, okay? And if you stress them too much, they can burst. Also, if there's too much garbage in the blood, they can sclerose, okay? They can harden and become less effective at delivering blood to their targets. The result is necrosis, tissue death, okay? Arteriosclerosis leading to heart failure is more common in type 2. Now, why is this? Well, in type 2, what's happening is that we're engaging in a lifestyle that tends to increase the amount of cholesterol and triglycerides in the bloodstream. In addition to that, we've got this problem with the insulin. The insulin's not effective anymore, and so we've got tons of glucose in the blood as well. And what results is that the walls of the arteries tend to collect something called plaque. Essentially, inflammation of the lining of the arteries causes stuff to stick to it, and part of that stuff is cholesterol and triglycerides. And what this does is this slows down blood flow. Okay, and what happens to blood when it slows down? It clots, and these clots, if they get thrown, can lodge in capillary beds. If they lodge in the heart, they cause a heart attack. If they lodge in the brain, they cause a stroke. Diabetic neuropathy can result from nerve damage due to impoverished blood flow, and this can lead to problems such as ED, incontinence, lack of wound healing, and loss of sensation from the area. This is why very often in diabetics that are in the later stages of the disease, what you see is as the nerves die, we lose the pain signal from those peripheral parts of the body, the fingers, the toes, the nose, the ears, and so forth. If you lose the pain signal and you injure the area, okay, or if the area becomes infected, the pain that would normally result isn't sent to the brain, doesn't make it, right? So what happens here, we have loss of sensation. If we lose the pain signal, what happens to our ability to deal with the injury? We don't deal with it, right? We don't feel the pain, we don't treat the injury. And the result is a massive infection leading to tissue necrosis. If the infection gets too extensive, it can get into the bloodstream, causing sepsis. If the bacteria get into the bloodstream, they can be carried all over the body, and this results in a condition called multiple organ dysfunction syndrome, or MODS, and this can lead to death. Okay, so you can see here how we have to keep this organ system, the endocrine system, working properly, because the effects of its malfunction are severe. Okay, that brings me to the end of this chapter. Please review this material as it will be covered on the exam. And if you have any questions, by all means, shoot me an email or call me on the cell phone or talk to me in class. And I'll see you soon. Bye.